This is episode 47 with Dr. Paul Anderson. Confused about how to navigate the conventional medical world from a natural perspective, and more importantly, how to protect yourself from the toxicity that comes along with it? Stay tuned because we are about to crack a piece of that code with Dr. Paul S. Anderson, who is the CEO of Anderson Medical Group, which includes Advanced Medical Therapies, a state-of-the-art medical center providing fully compliant IV, hyperbaric, and mild hyperthermia therapies, and a medical education company, Consult Dr. Anderson. He brings over 4 decades of medical training and experience together to allow his clinical and educational presence to grow and serve patients and physicians in the best way possible. He is a well-known continuing education presenter and author in the allopathic, naturopathic, acupuncture, and nursing CME arenas. His areas of specialty are in complex clinical medicine, intravenous and injection medicine, oncology, and genomics. He is the co-author of the Hay House book, Outside the Box Cancer Therapies, a guide for patients, families, and physicians. Dr. Anderson is the former Chief of IV Services for Bastyr Oncology Research Center and a past professor at Bastyr University, where he continues to consult in research, design, and holds the rank of full professor. He is a graduate of the National University of Natural Medicine in Portland, Oregon, and began instructing classes in naturopathic medical schools in the early 1990s. He is extending his medical education mission through the Anderson Medical CE Group site, consultdra.com, a web-based educational platform. And it is only fitting that Dr. Anderson is our first second-time full-length interview here on Integrative Answers to Cancer. I say full-length because we did have Dr. Ed Group back on recently to finish his 2-part mini-series on water fasting, answering all of your questions. If you haven't caught that one, go back and check it out, definitely. But as far as a full-length solitary interview, Dr. Anderson is our first repeat guest, which is awesome because he also just so happens to be the naturopathic oncologist that saw us through the most difficult time in Ryder's recovery from cancer right from the start. And back then, 4 years ago now, I was incredibly impressed at the way he was able to answer all of my questions on literally everything I had managed to scour off the internet before seeing him, and that was a lot. After moving states, we lost touch for a little while, and then we had some rather disappointing experiences with other naturopathic doctors. Then when I started going to these integrative cancer conferences myself to learn everything I could for Ryder and all of you as our online presence continued to grow, I started to see that he was actually the one teaching all of these other doctors, so they had some pretty big shoes to fill with us as it turned out. Still getting around to that new intro post-show rename, but for now I will tell you that you are watching or listening to Integrative Answers to Cancer, where all sides of the discussion on how to reverse cancer come to the same table to give you the most well-rounded perspective possible. And I am Ryan Sternagel of TheSternMethod.com, and I should probably still let you know that the information you are listening to or about to hear is for informational purposes only and is not intended to be a substitute for medical advice, diagnosis, or treatment. 2 things real quick before we get to the interview. First being, please do not forget to register to watch the Toxic Home Transformation for free. When our son was diagnosed, we did everything we could to reverse the cancer, but we also have done everything we can to remove the source of the cancer. If you're trying to reverse cancer, but you're surrounded day in and day out in your home by a lot of what caused it in the first place, that's a very big uphill battle that is absolutely not necessary to be fighting. And we know it can be hard to keep track of everything you might hear about that needs to be changed. Air quality, mold, EMFs, inappropriate lighting, household products, personal care products, and on and on. So we wanted to put it all in one place for you, and that is exactly what we did with our very good friend Robin Openshaw of GreenSmoothieGirl.com, interviewing 35 of our favorite health experts on all of this stuff, all in one place, and that airs for free on June 25th for a week straight, and you can sign up to watch the whole thing at TheToxicHomeTransformation.com. Also, if you're a regular here or with anything we do on social media with the Stern Method, you may know that I am unexpectedly sans day job. I am unemployed, or as a hat that I saw the other day I thought was cool said, unemployable because we are not accepting any other form of outcome from this turn of events other than us doing what we're passionate about full time, which is spreading information and inspiration on how to reverse cancer and on living a clean, healthy, fulfilling life with your kids and family. So we're working on everything we can do to make enough income to sustain ourselves going forward. This show is far from the most productive use of time in that regard at this point in time. Maybe in a few years that'll be a different story, but for right now, this is purely a labor of love for us. But we just can't stop putting out new episodes, even given the circumstances, because we know how much shows like this meant to us when we needed them. If you are interested in offsetting that just a bit for us, I will tell you a way that you can do that, and that is simply by giving us a thank you every month in the form of $3. If you're up for buying us the equivalent of probably not even a large but a medium cup of organic coffee every month, that would really mean the world to us. That $3 by itself isn't going to pay the bills or finish our house under construction that we're over budget on, but together with everyone else's $3, it will build to something sustainable for us over time. You can find out how to do that at thesternmethod.com/crowd sponsor, all one word. Only if you can afford it though, and I don't say that sarcastically. I certainly know how it is to need that last dollar. All right, with that, let's get to another all-star interview with Dr. Paul Anderson. Welcome back to Integrative Answers for Cancer. We have with us Dr. Paul Anderson, first time repeat guest to the podcast. How are you, Dr. Anderson?
I am great. Thanks for having me back.
I was just starting to say before we started recording that it's not like the podcast has been going for a long time now, but we've interviewed a whole lot of really good people in the couple of years we've been doing it, and your original interview remains one of our most popular for really good reason, and I would encourage anyone that wants a lengthy explanation as to your backstory and how you got into naturopathic oncology and so on and so forth to go check that one out for that, and for just because it was a really good interview. But you're back now because, well, for one reason, just you're awesome, but for another reason, you got a new book out. It's called Outside the Box Cancer Therapies, if I'm not mistaken.
It is. Yeah, thank you. It's just been out for a few weeks, and so far it's been pretty popular. So we're very happy about that. It was a long-term project.
Well, judging from the the dozens and dozens of pages of references in the back, and just the length of the book itself, I'm not surprised. Yeah. But cancer is not it's not an easy topic. I guess that's why that's why I'm doing what I'm doing and you're doing what you're doing. So I think one of the things that jumped out to me about this book early on when I was just thumbing through it originally was, there's a lot of natural cancer books out there, and they provide a lot of really good information and strategy and so on and so forth. But, when it comes, we're always advising people to seek out the guidance of a naturopathic oncologist, or, really work with in person a naturopathic oncologist that can, administer some of these therapies that you can't do at home. In addition to advising on supplements and diet and so on and so forth. But, unless you live in Washington or California or some of these other places, you don't have access to, a naturopathic oncologist right down the street.
Yeah.
But it seems like this book is one of the first that I've seen that you could literally take to, a naturopathic clinic that at least had, some of these therapies available, and say, I want to do this, I want to start with this plan right here based off this particular type of cancer that I'm dealing with. I see this plan right here. Let's just start with that. Is that one of the motivations for writing this book for you, or did you just do that on accident because that's the way your brain works?
Well, no, it was by design, and largely for what you just said. My co-author and myself, when we sat down to say, number one, do we want to do a book? Number two, how do we want to how do we want to focus the book? Because with cancer, there's a million ways you can write about it. There's a million things that people need to know. So I think you've interviewed Naisha Winters, my colleague, and she has this awesome book, and it's deep into the metabolic, treatment and all that. And so one of the great things was her book came out a year before ours, so we didn't have to write all that stuff. We just tell people to go there for that. That made our life easier. But the other thing was, when we were talking about it, Mark and I, we said, this this problem happens if we just take North America, where unless you're near a center, a city where there's licensed naturopathic doctors, uh, you're unlikely to encounter somebody who has this experience. And so, that might be 20 states in the US, and I think a half of the provinces in Canada. So, and then if you look at the rest of the world, it's a whole, other ballgame. So our goal was really to do something that we thought was unique, but now that the book's come out, I see is very unique. We wrote the book with, as you said, real live recommendations and ideas and all that, but we wrote it at the level that any patient with cancer, any parent, any loved one, any support person could read. So it's not a textbook, although it has textbook-like stuff in it. It's written so anybody can figure it out. But what we did, I think something very unique, is we referenced it the same way we would a textbook. And so, as you mentioned, there's like 70 some pages of references. We have just about 1,100 peer-reviewed references, and just about everything we talk about has references. And why we did that was not so much for the patient, although that's important, but we did it so that if they go to a doctor who's interested and open-minded but says, geez, I've never heard of this, they can go, and they don't have to start from scratch. They can go and say, okay, for turkey tail sounds awesome, but what is it? They can go and find the primary references. Or, I do IV whatever, but I've never heard of this thing. They can go kind of look that up. um, and the other thing is, as you know better than anyone, you also run into this thing where you may have an idea of integrative or natural therapy, and you bounce it off of your primary care doctor or your oncologist, somebody. The first thing often that they say is, well, there's no research about that, so we can't, we won't even entertain that. We put all that reference material in as a way to say, no, there is, it may not be the research you want, but there's a lot of it, and you have to at least give it some, some airplay in your mind. And so that was our goal. Was we knew there'd be more people, whether they're parents with children with cancer or adults with spouses or whoever with cancer, we knew there'd be more of those people who didn't have access to integrative oncology and naturopathic oncology, certainly, than did. And if they have an open-minded physician of any kind who's willing to do stuff, the book is a great blueprint for them to start. So they don't, like I say, they don't have to relearn everything we learned over, you know, if you count up the time that we've been doing this, it's over 40 years between the two of us just with cancer. So
Yeah, no, and it's you can definitely tell it's something that's come with a lot of time to think about this stuff, because it's
yeah.
yeah, it's just really well laid out. I like how because there's so many books that, like, it's just a big long list of different supplements or
Yeah.
different treatments and da da da, and like you have that list of the top supplements and the top IV therapies and so on and so forth. So you think for a minute, well, maybe it's just another list, but then you get to the next page and it's like, well, you just talked about the diet, then you talked about all the supplements, then you talked about all the treatments, and then you get to like the specific cancers, and you're like, here's how you combine all these things that I just talked about for this specific cancer.
Mm-hmm.
And you could literally just hand that plan to a naturopath, and away you go.
Yeah.
Which
Yeah.
is, go ahead.
And that was really our goal, and that was something that Dr. Stengler, who has written more to patients, I've always written to doctors, so I have a different writing style, but he and I work very closely together on that chapter that you're talking about okay, for this cancer, what do we think of first versus this cancer? And and so I was the original author on it, and then he looked at it and had me rewrite again, kind of at a different level. And the whole purpose behind it was, let's take all this experience where we've done all this, both research and trial and error and everything else, and say, these many decades in, when we see leukemia of this type, or when we see melanoma or whatever, what's our top five? What do we do first? So that the person doesn't have a list of 3,000 things that all might work, but they don't have any guidance. So yeah, we want it to be kind of general in the beginning, give the list, give why we like them, etc., but then be specific too.
And so, I mean, I'm sure it's obviously a complex question, but I mean, I don't know. Like we've had a lot of guests on this show. Some are of the cancer is cancer. It's the same approach no matter what. There's others that, I think go too far into the weeds of like specific, it's like an entirely different thing for every cancer. But I mean, in your view, like, what do you kind of, what does differentiate one cancer from another cancer in terms of how you look at it, and what you might apply, and the different supplements, and why some supplements might be better for one than another, or or IV therapies, you have different IV therapies for different cancers, and they're like, what, I don't know, aside from experience, what has been the thought process that led you to get that experience, I guess?
Mm-hmm. I think there's a couple of things. The They're both equally fitting into that kind of, where we got all this idea from. The first is that you literally can have two people the same age, the same gender, the same size, same cancer, same stage and everything, and they'll respond to the treatments completely differently. And so if that happens, now it's usually a little less variety if it's that close together, but if that can happen, then imagine somebody who's got like a stage 1 or 2 of a particular type of cancer versus a stage 4 of a particular type. They're going to respond very differently to the treatments that you do as well. So the first thing that that really requires someone to look and say, uh, this is why I want to start a little more conservative, a little more aggressive, is what's going on with that person, and what can their body handle, what can their body do. And so, for instance, when you look in the book, and we have certainly all the top cancers, we talk about specific things, but then we talk about other ones too. um, you might look at a list, or the lists that we kind of collate there, and you'll see that we say, these are kind of the main core things, and then these are optional that we would consider. Let's say IV was available or whatever. When we say we would consider, it may be if you have a real aggressive version, we might do more of those things, right off the bat. If you're a lower stage grade, you're pretty healthy, your body's got good immunity, we might start with the core stuff and then see how we do there, and then add if we need to. So I think that's one thing, is it doesn't have to be a complete shotgun. It does need a little individualization. But what our goal in that chapter you're talking about, where it's specific cancer and specifically where do we start, was we know regardless of how good or bad you're doing, we're going to start with these things for this cancer. I think the other side of it, though, and this is something I've been lecturing a lot of medical students. I mean, I speak to doctors every other day just about now, but a lot of medical students, I'm trying to get this across to them. And so I draw this kind of a pyramid, and then there's these 3 blocks that are at the base. And what I say is, after all these years, what I found is what I'm about to tell you is true. And that is that the pyramid contains what I call all the cool therapies. So that's, and there's a million of them, but whether it's curcumin or mushrooms or IVs or whatever, and they're all good. They're all really necessary. But if the 3 blocks aren't being addressed at the bottom, what I see just from looking backwards at all the thousands of patient interactions I've had is, if the fundamentals are not there, the cool therapies are not as strong, and they kind of fall through. They'll work for a little bit and then they kind of, crash. if the fundamentals get built up, and they don't have to be there in the we work on it and people work on it, but if the fundamentals are there, the other therapies really have a lot better chance of working and are stronger. And the short version of the three fundamentals is your food and fuel. The middle one is muscle, and then the third one is brain. And the bullets there are whatever way you address the food thing. So it could be something like the metabolic approach where you're really going to dial into keto or whatever. You're going to do maybe a different version of that. Whatever you're doing there, the food has to be as clean as possible, because there's no point in retoxifying yourself with toxic food, because we got to eat, and that's one of the biggest ways we get toxins in, outside of breathing. Uh, so clean food. The what and the macros and all that stuff, which that's an individualized thing, and then the timing. And we know a lot more now about intermittent fasting, all that stuff, and so we actually have patients eat on a feeding window and then a non-feeding window every day. So that's one thing.
What is the what's Anderson's ideal feeding window?
Well, it depends a little bit. The Another really stroke of great luck with a publication was that the human breast cancer survival study that we quote in the book came out, where all they did was, I mean, and when I say all they did, it was a great study. We would have done the diet differently, but we weren't in charge. So what they did is they took breast cancer survivors, same homogeneous group, and they just randomized two groups. One is eat what you want when you want, we don't care. The other is eat what you want when you want, but limit it, so that you have 13 hours where you're not eating every day. So all they did was a 13-hour fast. You could have water and stuff. In the group that the only change they made, no diet change other than the timing, they had a third less recurrence of breast cancer. Pretty impressive.
Okay.
Now imagine if you cleaned up their diet on the other side and all of that. So because there's always, concerns with cancer patients about caloric intake and all this stuff, which we'll talk about in the second pillar, we start with 13 hours because we know at least that's where the metabolic reset seems to be. If I have somebody who is struggling not just with cancer, but they've gained a lot of fat weight, let's say, and they may be pre-diabetic or diabetic, we will actually work with them to do a longer fasting window every day until their chemistry calms down. They start to gain muscle, lose fat. But 13 appears to be, which is easy for almost everyone. Like, people think they're going to die if they fast. 13 hours, you're asleep for most of it. So it's really not a big deal. It's,
Yeah, my
it,
I'm doing this Toxic Home Transformation Summit, and my co-host is Robin Openshaw, and she I just saw her do a Facebook post recently. It's like, it's not called intermittent fasting. It's, the time between dinner and breakfast. Which is,
yeah, it's
yeah.
yeah, and like I say, you get somebody, they have metabolic syndrome. You push it a little longer, and actually, it's very, very helpful.
Yeah.
But that leads into the second pillar. I call it muscle, just so people remember. But survival from cancer wise, just looking at that, the more muscle mass you have and the less fat mass you have, the longer you live. And there's a lot of biological reasons for that. And the North American cancer world has forgotten about that, and they look at just, well, you don't want to lose weight. Well, you also don't want to gain fat mass, because fat mass fuels the wrong biochemistry in your body. Muscle mass fuels the right biochemistry. So we really work with people. We don't want them to lose weight and get cachexic, but we work with them to say, it's your muscle that's the most important. And so we're going to work on that. And that actually sends signals out to the rest of your mitochondria, the rest of your body metabolically, that says, we are in this direction of metabolism. So let's y'all get on board. And it can actually slow down metastases, et cetera. I mean, it's a deep well, but muscle's important. It's not weight, it's muscle. And that goes to the also time, restricting the time of eating, all that feeds into that.
Yeah.
And then the third one being brain is not just the shock of getting a cancer diagnosis and what that does to your mind and all of that, but once you get beyond that, it's what you do with it here, as you progress forward. um, and again, people who get stuck in, we go through phases of disbelief and denial and anger and all that stuff. If you get stuck at any of those places, especially in either disbelief, and so you don't believe you have cancer, or anger, anger and anxiety, or they're all toxic. So what we really work with people, and if they need, there's really great people who do therapy in this area. We'll get them hooked up with. They have to honor that process. It sucks to have a cancer diagnosis, but then they got to get to the place where they're not a victim. This is something they're taking charge of, and they're realistic about it. But they're moving forward, and it's not, and that's associated with longer life too. So I think when you put those things together, between the mind end of it and the diet metabolism end, you could see that then the triangle of cool therapies are going to work better if it goes into a body that's doing that. And that's why we tell people, like, you have control over those three things: what you eat and when, if you exercise, try and get your body working, and then what you do up here. We can help you with it, but that's in your ball, your court. And then we can do the cool therapies, and I guarantee you they'll work better if they go into a system that's trying real hard.
Yeah, yeah, no, it's the whole picture for sure. Which is, yeah, I mean, and that picture is tough to to really paint sometimes for someone just jumping into,
Sure.
and
Yeah.
everyone is just jumping
Yeah.
into it, really. They're,
Right.
you're forced into this whole thing. But
Yeah.
uh, I uh, I had a good transition in mind while you were talking, and then I lost it to the next question that I was going to, or the next topic that I wanted to bring up. But uh, yeah, I can't think of what that smooth transition was, so I'll just reset. Um,
No
so
need for smoothness.
no need
It's
no
all
need for
okay.
smoothness in cancer. It's rough. Uh, so you and I, like, before we started recording here, we were just talking about um within the world of natural approaches to cancer, there's a whole nother world. Like, it's not just natural or integrated or conventional. It's, there's like the truth about cancer. A lot of guests we've had on this show, it's no chemo, no way, no how. And then there's a lot of the very conservative naturopathic oncologists that tend to have a lot of letters after their name, that that they won't work with you unless you're participating in the conventional medical system.
Yeah.
um I know, you know better than anybody how well the natural stuff can work, especially when you have all the fundamentals down. I mean, where in your mind does I don't know, does the conventional stuff become necessary at some point, or should you make the, I won't ask you to say should, but, might it be advisable, or for someone to at least start trying just all natural, that sort of thing? What goes into that thought process for you?
Yeah, and actually, that's not too clunky of a transition. That's a good logical next step from our previous discussion. Um, Here's the thing, and this literally was something that, before we got to the point of even putting a book outline and an offer together for the publisher, all that stuff that Mark and I talked deeply about. And just quickly, when I talk about Mark, so his name comes above mine. We're co-authors on the book. Mark Stengler, he practices in Southern California, and he and I were in medical school a long time ago together, and we had literally not seen each other for almost 20 years. And he came to a cancer conference that I was teaching at, and afterwards we kind of reconnected, and found out that his practice had kind of evolved into a lot of integrative oncology, and mine had too, and we were comparing notes. And what turned out was they had evolved in with similar philosophical underpinnings, but in very different ways as far as therapies and all that stuff went. So when we merged those two together for the book, it was really nice because we both had really deep clinical experience in kind of two different approaches to looking at cancer. And we had what worked, what didn't, we got to share. So um, when we were talking about it, though, before we got to that part, we both kind of said at the same time, so how do you look at what you were just talking about, this idea that, there's the total, like, stick with the chemo and radiation and all that, and then we'll maybe fit in somewhere. That's kind of the one conservative end. Then there's the don't do any of that, and we're going to go way out here and do other stuff. you know where do we both land on that? And we purposefully used the term integrative oncology through the book, although we're both naturopathic medical doctors and we both do naturopathic oncology. And we say that obviously, but we use the term integrative oncology because in our world, and what we found works the best for patients, there's no bad medicine. There's just bad timing and inappropriately applied medicine. And so what that means is we meet each person, and we have a whole. I got to write this part, and it was exciting to be able to write it. And then he kind of cleaned it up so people could understand what I was saying. But he had to do a lot of that. When you write only to doctors for 40 years, you learn bad habits. Doctors read differently. But what we wrote about there was, if you look at a one size fits all on either end of those spectrums, you will never get the right answer. And we've seen this over and over. And so that's the same whether it's the all natural end of the spectrum or the all conventional end of the spectrum. If you look, and I've actually heard doctors, kind of on TV saying, there's no point in integrative oncology because we have, 90+% cure rates with some of our therapies. What they're saying is, there's a couple of cancers that have super high cure rates with standard therapy, great, but they're extrapolating that to every other cancer type, which we know doesn't have, 90% cure rates, right? So what we first do with a patient is say, what stage of the cancer are you at, and what is the likelihood standard therapy is going to be really helpful? Okay, if it's a high percentage, 50, 70, 90% or whatever, we will say, patient, it's up to you. But if it's a 75% likelihood it's going to be helpful, why don't we consider that, but consider doing things integrative wise so that doesn't do you in or make you sick or whatever. Great. But we also get people, I was just talking to a friend the other day, and their brother had a pancreatic cancer diagnosis, and the oncologist even said it's 3 to 4%, chance that all this surgery, everything we're going to do is going to do anything for you. And they said, well, so could we just take some time and do something different? The oncologist, yeah, he says this is just going to be a really, like getting hit by a truck if you do this, and it's not too, not too likely. In the time that they made that decision, and then they completely changed their life and changed their diet and did a bunch of stuff with Dr. Winters and all this stuff, they had their PET scan went basically negative, like the cancer went quiet. So it just illustrates that you have to be rational about it, and you can't just sit back and say, we always bow to standard oncology and then everything we do is under that, or we always only do, the natural things and we hate standard oncology. There's no good answers in either of those. So we literally go through that calculus with a patient. The other thing you see is if you got stage 1 or 2 breast cancer, totally different thing with standard oncology than if you have stage 4 breast cancer spread all over your body. The standard oncology thing is a different answer for each one of those things. So our goal, if let's say you've got cancer, there's 4 stages we look at. The first stage is not getting cancer, so that's primary prevention. That's what we all should be doing, right? But you get cancer, you're now in stage 2. There's active treatment and then recovery from active treatment. Now, active treatment, if it's super high success rate with standard therapy, what I was telling them, that's one little slice of the pie. The rest of the pie is for us. and we need to take care of you while you get that standard therapy. Then the next thing is recovering from standard therapy, which is even more important, because something that uh, I just, it was like going to Disneyland for me, I got to write about, was in the recovery and then the prevention after cancer diagnosis, is the idea about cancer stem cells, and how the standard therapies actually make them stronger. And so our goal is, and that's not a, you don't have to let it do that, but if you just do standard therapies, they get stronger, and eventually you get different or better cancers later in life. Well, there's tons of stuff that we can do, both with those kind of pillars of, the foundation, but also with integrative and naturopathic approaches that will keep the stem cells quiet and not aggravate them after the chemo or radiation or whatever. So as we go through with people, there's, what stage are you in? Are you getting active treatment, or is that it's a low payoff, so you're not going to do that? We do different things there. Have you had active treatment? Your body's wrecked. We need to recover it. A lot of patients there, because the better you recover after active treatment, the longer you live and the less recurrence you get. Or are you no evidence of disease, and now the deal is, let's never get cancer again? Totally other way to look at it. So I was in this, I was telling medical students this, and you see their eyes kind of roll around in their head a little bit, but it's like, even if the person does choose chemo, radiation, surgery, or whatever, and that's a 90% success rate, let's say, it's literally 10% of the care that they need. But if you come from the standard oncology world, that's all you see. But it's like, they have they have a body full of cells that don't have cancer, that need to be protected, right? And you got to get out the other side. So I think, we really, and it's not like we're not being centrist about it in saying that we always wind up in the middle. What we're saying is, be logical. If any therapy has a super high chance of working, do it, and then figure out what else you need. If therapy is unlikely to help you and give you just side effects, and the oncologist nowadays will usually tell you, I wouldn't even do it myself. I've heard that.
Yeah.
Then there's tons of stuff you can do too. So I think it's a matter of meeting the patient where they're at, realizing that there's no one axiomatic truth answer that goes either direction, and just moving forward. And I think, that's happened over time as people get more comfortable. You mentioned, there's a lot of the integrative and naturopathic oncology people that kind of go one way or the other. And I think what they're saying is, there's something that's more encompassing, that's a better way. And that's another reason we wrote the book, really.
Yeah, yeah, no, and it's funny. It seems like, maybe I'm just hearing about it more, but I think traditional standard oncologists are coming to terms with the fact that their stuff just isn't going to work on some people, and they're okay with that, and not maybe trying to make as
Yeah.
big of a charade about it as they have in the past.
Yeah,
Um,
I think that is getting to be more of a thing. And I think that that's something we always tell people to kind of shop for when you're looking at oncologists, is just a realistic point of view. And that, if you get an oncologist that literally will look you in the eye and say, if it was me, I'd definitely do this, or if it was me, I definitely wouldn't do it, they're taking a bigger view. It's not just, my medicine's the only way to go. And there's a lot more of those people out there now. So I think that's an important thing to say.
yeah, yeah, no, it's our oncologist that we've had for the past few years is, he knows that there's a whole lot of other stuff out there that isn't his stuff, but he's not discrediting any of it just because he doesn't know about it,
Right.
which is pretty
Right.
cool.
And
Um,
that's not the experience you had initially.
no,
Yeah.
certainly not. Sometimes it takes driving a little way across the country to get that guy.
That's
um, so on that note, though, I think whether people choose not to receive any standard therapy or not, they're still going to be interacting with the conventional medical system, at least for diagnostic purposes. I think just about. I mean, there are great Jenny Herbachik's book, Cancer Free, Are You Sure? We've had her on the show,
Yeah.
documents, all the different alternative, if you want to call them that, blood tests there are, and thermography and so on and so forth. And that's, it's really, it's good stuff and everyone should do that. But all the same, I think most people these days are still going to their, oncologist, their hospital, whatever, and getting some of these more traditional tests. That's on our mind right now because Ryder, my son, is due for his, it's going to be 4 years. It was actually 4 years yesterday that he was diagnosed, 11 days before his first birthday. So it's um, yeah, but
Wow.
anyway, so we're
Wow.
coming up on 4 years here, or excuse me, it's his 4 year scan, I guess you could say, that we're coming up on, and I was just asking you about gadolinium. It's what they use for contrast in MRIs, and I thought it'd be neat just because I haven't really heard this discussion, even in integrative discussions, dealing with some of this type of stuff and things that people are going through, whether they're going, whether they're doing all natural or conventional or whatever. They're still getting some of these basic scan things, and I haven't
Sure.
heard a whole lot of
Sure.
discussion on how to mitigate the effects that you are going to get. So I thought that'd be cool to spend a bit of time on that specific thing. And just, I guess, to start, MRIs, the contrast,
Yeah.
there's no contrast, is there a need for it, isn't there a need for it, what can you do if there's a need for it, that sort of thing. Could you just riff on that for a few minutes?
Yes. So, um, yeah, we had a long offline discussion about that, and I think that just to bring people up to speed. So, if you've had MRIs or your child has, et cetera, you've probably encountered contrast versus no contrast. A lot of reasons that the radiologist will decide to go one or the other. So that's one issue. The other issue, though, is that one of the most common things used as a tracer, as contrast, is gadolinium, which is a metallic substance, and it goes through the system, and then it helps to outline certain things, etc. Initially, decades ago, when it first came out, they said it's inert, it's excreted by the kidneys, we don't have to worry about it building up in people, etc. And we've all heard this story before, and then 15, 20 years later, well, maybe we were wrong, and now there's some toxicity, and now um, I I have colleagues who are radiologists, and it's now becoming this big thing, that this whole thing that we thought was safe now turns out can be toxic, which we have known for a long time. And now they're going through and they're basically recommending it as little as possible, unless you really, really need it. But the problem, as you said, stems from the fact that, which is part of life, if you have a diagnosis like cancer, there's probably going to be imaging involved of one kind or another. Now, if it's MRI and then there's gadolinium involved, you need to be clear with your care team. Do we really need it? And if it's super critical to, it's like the only way they can see that type of tumor, they know that. No, they should be transparent about that. If it's just a nice to have, as we would say, it's a little better, but not, it's probably better not to do it. Um, One of the reasons that one of the later chapters in the book is it's recovering from standard therapy, and so we have a whole chapter on that, because it's like that's become a big portion of what we do in naturopathic and integrative oncology. Well, gadolinium is in this super special subgroup, and because one of the things I educate doctors about is metal toxicity and prevention of toxicity during, say, metallic chemotherapies or contrast agents or whatever. There's a lot of research into what's probably good there, but it's not really well known broadly, even in the integrative community. I mean, I probably get uh, the internet is really wonderful because everyone can find me. So I probably get, you know, 1 to 2 to 3 requests a week to just do some training about gadolinium because it's become such a problem. And I was teaching a course 2 weekends ago, and I ran into a doctor who was able to get a waiver to use the really super special, government only gets it kind of chelator for gadolinium. And I said, I'd smile. I said, well, how's that working out? And he says, it seems to make people sicker. And I said, yeah, that would make sense because it's the super special chelator that binds the gadolinium, but that means it has to travel through your body before it leaves. And so the bottom line with gadolinium, this obviously won't be at the level that we would do in a doctor training, but there's concepts that are important. The first is, let's say you've maybe never had a scan, but they tell you we have to use gadolinium because it's the only way we'll find out if the tumor's here or there or how big it is, whatever. Okay, there's ways you can protect yourself and help to make sure that the gadolinium moves through the body more appropriately and leaves. Because what you want is you want it to go in, do its job, and then leave. You don't want it to stay. Some people, genetically, other reasons, their bodies don't eliminate a lot of metals very well. So what you want to do, because you won't know whether you're one of those people or not, is you want to do a kind of a two-step approach. One is let it move through and promote it leaving, which is mostly through the kidneys. So there's the promotion of removal. But then the other thing, which is more critical in my mind, is why don't we set you up to protect your vital organs so that they're damaged as little as possible as the metal moves through. So this is brain, heart, liver, other muscle, and especially kidneys, because the kidneys get the brunt of most metals that they got to go out that way. So what we normally do, and this is similar to what you and I talked about, I think offline, but we'll do protective things beforehand, unless the person's already had the scan. But if they have a little bit of time to plan, we'll do protective things such as N-acetylcysteine or alpha lipoic acid. They're they're both thiols, they're sulfury molecules, but they're both related to protecting, especially kidney, from these different agents. They work with a lot of different metals. They're very well tolerated. There's a few people who don't tolerate them, but they're very well tolerated. And you can take them before and kind of raise your levels so that when you do get the scan, uh, whatever it bumps into isn't already oxidized and doesn't get damaged as much. So there's that protection in. There's also the cheapest protective substance in the world, which is vitamin C. And we usually give people like ALA or NAC and vitamin C together. The vitamin C takes a different angle on this protection, and it's almost I've seen this over the years. It's almost like we hear about vitamin C so much, we almost now think, oh yeah, vitamin C, whatever. But it's like if you don't have very much money and you want to protect your body against oxidation, vitamin C is the cheapest thing that you can buy to do that. And thankfully NAC, ALA are not as expensive as it used to be, but vitamin C is really cheap. So we usually give vitamin C and probably a few trace minerals and stuff beforehand. The other thing is, if again we talked about like things you can do yourself, diet stuff. If the person is either doing like whole juicing, like you'd get with a Vitamix or a Blendtec or something where you're keeping the fiber and all that stuff. We like that, especially in this setting, for a couple reasons. But the biggest reason is in the whole juices, you not only get all the little micronutrients, but you get the big flavonoids, polyphenols, all those good things. Those are also, when it comes to kidney, brain, heart, liver, they are super, super protective in the system. So this is something you could be eating while you go through. Now, if you don't have an expensive, whole juicer or whatever, you can do light cooking, with the same vegetables and stuff, and it kind of breaks open the cell wall, so you get more of those nice polyphenols and stuff. So a quick stir fry or a quick steam or something like that, you can get pretty close to a juice. So all those things on the front end, and of course after, they're important. After you have it, you definitely want to keep the protective antioxidant things going. But then you may want to, and this is something I'd probably recommend you work with a practitioner on because there's a little bit of monitoring involved, but you might want to use something like, say, a liposomal EDTA, or something that's a more of a binder on the way out. And there's kind of two ways, I'll just to be oversimplified, but there's two ways to get these things out depending on where they land in your body. One is actually to bind it with a chelator, which EDTA, that's what it does, and it helps it go through the kidneys. So again, the better you prep the kidneys, better that goes. The other, though, is polyphenols and other things will send some of it out through your liver, which will get into your bile and then into your digestive tract. So then having binders that don't let you recirculate it into your blood, like psyllium or charcoal or things like that, that help just kind of keep stuff moving out. So on the after the scan things, we're looking more at binding it one way or the other. And what I will say from seeing a lot of cases, and now working with other doctors who bring me these cases that are not turning out like they ought to, um, the better you prep the person and then the quicker you move the stuff out, the less damage. The longer it circulates around in the body, the more sick they were to start with, the more oxidized. Let's say they're, especially you're eating the traditional, American inflammatory diet, and you don't have a lot of micronutrients. The gadolinium is just going to go in and be like, kerosene on the fire there. So I think really important that, it's an agent, and if you really do need it, there's ways to protect yourself before and after.
Yeah, yeah, no, that's yeah, I'm glad we got that recorded because yeah, it's been a concern of mine for a long time, and I know it's just something that a lot of people just don't think about.
No.
I Yeah, I was also asking you about, and it's for us in particular, every time we have to get a scan, it's not anesthesia, but sedatives, and
Right.
um, because you can't have a kid just sit there, through an
Yeah.
MRI
Yeah.
for an hour.
Exactly.
It's not gonna work. Um, but even a lot of adults, I mean, you're getting anesthesia if they have to go under for surgery or a biopsy or da da da. And I know you mentioned similar protocols for those two things. What was the difference, or was the differentiator, in like anesthesia, sedatives, that sort of thing, versus gadolinium?
Well, of course, it's a similar logic, which is, prepare your body, et cetera. But and anesthesia, of course, breaks down into a number of different chemistry types, and so if a person's getting, for example, an inhaled anesthetic, those kind of process in one way through the body versus what they often do is medical sedation, where you get an IV with a cocktail of things that kind of just make you um, either totally unconscious or next to unconscious and very relaxed, and they work differently. So the first thing is, if you're really getting a lot of that, or you're going to have a long surgery or something, uh, it would be good to work with somebody who could look at the pharmacology of the drugs you're going to get and basically support all the exit pathways for them. So yeah, there's the prep thing, but the exit is different. So a metal, the exit is, it's got to be bound up somehow and get out either through the feces or the urine. Anesthesia, whatever way it goes, is going to go, and there's three primary phases of liver removal. Phase one is the best known, as far as we know. X drug hits phase one at this point versus this one, or at these 2 points, or whatever. Those are very stable, predictable reactions in phase one, and supporting them is mostly minerals. That's an oxidative step, and it uses lots of minerals. So we usually have people just kind of generally do trace mineral mix, that sort of thing, to support that. Now, if we know that the drug goes through a particular phase one pathway, and we know that the person has genetic troubles there, we may give them extra of whatever helps that. So that's phase one. Phase two is where you kind of customize things. And so the addition that you certainly could do with gadolinium too, but we didn't talk about what gadolinium is. Phase two is heavily supported through the glutathione system. And that's how you get that. Like, so let's say phase one, it takes the drug and makes it into an intermediate. Phase two then either uses something like glutathione or a specific enzyme or glycine. Phase two puts an anchor on the chemical so it leaves you. If you run out of glutathione and it's a drug that goes through the glutathione phase two pathway, it just goes back in your system as an intermediate and can make you sick. So glutathione levels, which can be improved by like NAC and ALA, but really now that we have really nice liposomal glutathione, we normally have people do that around anesthesia, and that in itself helps a ton. Because you see this with kids with just dental procedure. They'll do sedation for dental procedures. Kids do much better if their glutathione levels are elevated. And then phase three works on basically, now that it's bound up to this stuff, how do we get it out of us, which is kidney and bowel function, stuff like that. So I think that the one addition, other than the minerals generally for phase one, is support phase two, and that's a lot of glutathione. And there's a couple of herbs that are well known to help, like milk thistle. Uh, Really, the way that it helps though is it makes the liver hold on to glutathione longer, so it's sort of a good one too.
I like it. That's one question I have for you. When after we were talking about this the other day on the vitamin C, you had indicated kind of a more the better sort of thing,
Yeah,
which is usually the case with vitamin C and cancer in general.
right.
Um, is that so? Like when you're doing if you're using vitamin C like high dose for anti-cancer purposes, and say
Right.
you're getting IV, or maybe you're doing high dose liposomal or something like that, it's kind of like a one day on, one day off type of strategy.
Hmm.
Is that the same thing here, or would you be looking to just get a whole lot of it every day in?
Yeah, I think certainly if someone's already doing a fairly high dose vitamin C strategy because they have cancer, they don't need any more. I mean, that's very sufficient. A lot of people, however, aren't doing that, and so if they're going to go have a anesthesia, or they're going to have a contrast or whatever, that's a good thing to start. Uh, we should probably say, the limit with vitamin C orally is usually you'll get diarrhea. So we don't, once the bowels loosen up, you don't want to go higher, unless you're doing a detox or something. Like, don't do that. And that's here's the thing that people, even doctors may learn this, but most don't. But it's in biochemistry. Your digestive tract, when you are under stress of any kind, infection, cancer, whatever, it has transporters for vitamin C. And so when you're totally healthy and happy and there's no troubles, it doesn't absorb a ton of vitamin C. It's hundreds of milligrams a day. When you get under stress of any kind, which cancer certainly fits, but also surgery. So one of the things that I remember, this is a old recovered memory, but when I was sorry about the sirens there. Um, when I was in training, and I did this, I thought this would be a great thing to do, and it was. I did this mixed training, so I had a very allopathic side of my training that involved big clinics and hospitals and stuff, and then I had the naturopathic side, and it really was helpful. But I remember one of the things back in those days they used to tease me about was vitamin C, and the doctors would all say, "Well, you only absorb a maximum of 600-700 milligrams a day. So you people, it's all you people giving all this vitamin C. You're just making them poop more or whatever." Um, what we found out since then, because we saw it clinically, is the physiology of the GI tract is more well known now, and you can literally go from needing 700 milligrams a day to absorbing 6,000 milligrams a day when you're under stress, et cetera. So we do tell people, if they're not experimenting with vitamin C, divide it up during the day. And for an adult, we start with like 1,000 milligrams with each meal. And sometimes they'll say, "Man, I'm taking 3,000 with each meal, and I'm not having any bowel troubles. Well, guess what? Your body is sucking that up into your system. When you start to have loose bowels, it means you filled the tank and you can go on the other way. So just, that's the only caution really with it, but it's the least expensive thing you do, probably the most helpful, and it's water soluble, so you need it every day.
There you go. There you go. Couple minutes left. Do you, I mean, just on the, you mentioned you got a whole chapter in the book on just recovering from conventional therapy, which again, I just encourage everyone to go out and get the book. But just high level thoughts there on like, what is it exactly you're recovering from, and what are the, kind of the
Yeah,
the
yeah,
main strategies of doing so at a high level, I guess.
yeah. I think first thing is the logic is exactly the same as like talking about gadolinium or anesthesia. There's sort of, if you have the opportunity to prep beforehand, there's things you can do proactively. But a lot of people come to us and they say, well, I'm done with radiation or chemo, I don't feel well, what can you do for me? You got to start where you start. um, you'll see in the book that we divide it up into strategies, and so we give the what does this procedure do to you first, biologically and chemically and all, and then what do we do to get out of that? We have different strategies for surgery versus radiation versus chemo, because they're all different sort of insults to the body. Now, some people have had all three and they need everything. But the bottom line is, if there's a chance to do preventive things before you get surgery or before you have radiation or during radiation, whatever, what the preventive things do is take down the damage a number of notches so you get out the other side and you're not nearly as wrecked. But if you don't have that occurrence and you didn't know about these other things, when you get done with chemotherapy, for example, you have to consider, the first thing I'll tell a lot of adult patients is, I'm more concerned about the part of you that doesn't have cancer than really the cancer. The cancer is what it is, and we deal with that. But most of you doesn't have cancer. Chemotherapy, for the most part, doesn't care which kind of cell it is. The U good cells and the U bad cells, they all get the same thing. So what we do a lot there is say, great, you beat up the cancer cell, but the rest of us took a pretty big hit. So there's a lot of recovery. The recovery starts really basic with the antioxidant system, includes fat soluble things like, tocotrienols and tocopherols, the vitamin E family, the good fats, like the omegas, phospholipids, vitamin C, our old friend, and glutathione. All that stuff kind of goes together there. Um, and then there's specific things. For example, if you have the very common platinum chemotherapies, the nerves and the kidneys take huge hits there. So we do a lot of kidney regenerative treatment and nerve protective treatment. You might get a chemo that doesn't do anything to your nerves but wrecks your GI tract. Most of them do that. So then, if you don't fix the GI tract, like it's like you've taken, the biggest, you remember the first pillar is food. Well, that has to go in your GI tract. It's like you have this giant hole in the system that, can't work. Right. So a lot of it is there's the chemistry, getting over the chemistry, and then there's fixing the organs that took the brunt of the chemo. Radiation, kind of similar, depends where they aimed it. If you got brain radiation, it's a lot about recharging the brain. If you got local radiation to your liver, it's about that. And then surgery is a little more global. That's a lot about supporting healing, and we go into what does that mean, and how deep and all. But it all starts really in the cleanup with what organs got hit and what do we do for them, and then what do we do to bring the oxidative balance back into the person, and antioxidative balance, because we need that, but we need it not to be way out of balance like it was during chemo, let's say.
Beautiful. Dr. Anderson, I could pick your brain forever, but we'll have to get you back
Uh,
on for maybe it'll be the first ever third time guest as well.
I love talking to you. I can't believe it's been 4 years.
Yeah.
um, I there's something when we do these is people don't know probably, but when we have these conversations, especially when I can see your face, it does. I like have flashbacks to the first time that I met you, which was under some fairly stressful circumstances, I think for you guys certainly. And it's one of the things that you see talking to thousands of people is I could tell right away you guys were not only, on it and not only dealing with the shock of everything, but like you had done more homework than most people I'd met in a very short amount of time. And I felt like you had some really good questions, and you always had a lot of them, which was good. That's how you learn, right? And it's honestly, I think of that when we were writing the book, we were thinking, well, what about people like you who there's nobody they can go ask these questions, so it's like we said, well, let's at least put it in a book, and then they can find somebody to work with, and so I'll just show a picture of the book in case people see it. It's like a target with a square orange in it. So I get a lot of a guff about why did you use the orange. Number one, the art department did that. That's for aesthetic reasons.
I was
We're not
wondering whether it was an orange or a grapefruit, but yeah.
Yeah, we're not promoting square oranges at all or anything like that. It's just it's they thought that was cute, and I guess it works. So there you go. Well, it's great talking to you. Thank you for having me on again.
Very good talking to you. And yeah, the joke I thought of when you said, "What do you do for people like me?" is people like me start this podcast, and now
Exactly. This is the next logical step for you.
It really, I went from like begging people for 15, 20 minutes of their time, or like, you probably noticed we wouldn't have official, consultations set, but we didn't be in there for IV vitamin C or whatever. And I'd be chasing you down, asking you more questions then. But yeah, I went from getting my information that way to just, now I get to spend all the time I want with people. So it works out good for everyone.
Good. And now more people can hear the story too, which is the most important part.
Yes, and that's what I meant by the grand everyone. Yes.
That's right. All right. Well, you guys, all the best, and I'm sure we'll talk soon.
Indeed, Dr. Anderson.
All right.
Thanks for websites, Facebook, all that stuff. Where can people...
So if not necessarily that people would need to go to the clinic, but the place where patients, there's some videos and things about what we've been talking about. That's kind of on our clinic website. 4 words run together: cancerandchronicdisease.com. Cancerandchronicdisease.com. That's the clinic website. Facebook, just search Advanced Medical Therapies. So just Advanced Medical Therapies, and they all lead to the same stories and stuff. If you have practitioners who are looking to search different things in that, there's a website called consultdra.com, just consult DRA, and that has kind of where I'm speaking, and it has a lot of Q&A I've done over the years that you can search and all that business. And I think those are probably the easiest ways to find out what I'm doing.
Sounds good. And I think we just held up the book just now and didn't actually, it's Outside the Box Cancer Therapies for anyone that's not watching this on YouTube and listening on iTunes or Stitcher or something like that.
Yeah.
Outside the Box Cancer Therapies.
Yeah. If you got to put all the words, there's a lot of outside the box books, but Outside the Box Cancer Therapies and Anderson, and that'll get you you see the square orange, you're there.
We shall link to it in the notes of the show, which I'm going to have to figure out what, it's usually just / Paul Anderson, but we already have a / Paul Anderson. So I will figure out what to call this and tell everyone in the outro. Dr. Anderson, thanks so much for coming on.
Thanks a lot. Bye.
There you go. Dr. Ray knocks it out of the park again. Let me know what you thought of this episode in the YouTube comments or in an iTunes review or at thesternmethod.com/Paul Anderson. Outside the Box Cancer Therapies with dashes in between all of those words after the /. or you can just go to thesternmethod.com and find it there. But do let me know what you think about this. We've had a lot of the purely natural folks on the show, and not quite as many of those that work alongside the conventional medical system, but I'm trying to balance that out with more naturopathic oncologists and integrative coaches and the like, if that's what you want to hear. So let me know in the comments of your platform, of the platform of your choice, because this show really is here for you. Speaking of here for you, don't forget about that $3 a month if you're willing and able at thesternmethod.com/crowd-sponsor, all one word. And again, please do watch The Toxic Home Transformation, which is even less than $3. It's absolutely free, starting June 25th, and you can register to do so at thetoxichometransformation.com. Don't forget to subscribe to this show however you're consuming it, on iTunes or Stitcher or YouTube, for more interviews like this every week. Music, as always, was provided by one of Ryder's favorite artists. Fact of the day for you, and that is TheFatRat, along with Tasty Network, and all production was done by the one I couldn't live without, Teddy Sternagel. This is Ryan Sternagel, and you can find all the Sternagels and everything we do at thesternmethod.com. If you are going through cancer, just keep going. That's all for now. God bless and Godspeed.